Bonjour, everyone. It's my great pleasure to be here today and to share on behalf of my collaborators the experience with the I-SPY 2 clinical trial. If I can get my first slide. So this is a trial that is being held at the United States of America. It's a study that has been ongoing for the past 10 years, and it is a study that is characterized by the willingness to apply personalized medicine to the next treatment. So here are my disclosures. I work at the University of Texas MD Anderson Cancer Center, and the other disclosures I have here will not have anything to do with what I am going to discuss with you today. So in the next 15 minutes, I expect to be able to talk a little bit about breast cancer treatment, especially early stage breast cancer, and then talk with you about the I-SPY 2 framework and what we have achieved so far, introduce the I-SPY 2.2, which is an update of that trial, and then get to the conclusion. So as you know, the breast cancers are not all the same. Typically, when the patient presents to us in the clinic, the diagnosis starts with imaging that may include mammogram, ultrasound, and MRI. And then we get a breast biopsy that confirms the diagnosis. And then we get mainly 3 receptors, which are estrogen receptor, progesterone receptor, and HER2. Based on that, we classify the disease into 3 main groups: the hormonal receptor positive, the triple negative breast cancer, and the HER2 positive. There are subdivisions to that, but these are the main 3 groups that have been used for the design of clinical trials in the past several years. And then we also typically have to proceed with the clinical staging that may include additional imaging. And as you can see, we have, I knew I was going to do that. We have patients with early stage disease, which is really a disease localized to the breast and regional lymph nodes. And sometimes we have also systemic disease, which represents metastatic disease. So I-SPY 2 essentially concentrates in high-risk early-stage disease. So treatment of early-stage breast cancer for a long time was based on surgery followed by several different types of adjuvant therapies to try to decrease the risk of recurrence over time for that particular patient. The limitation to this approach that is represented here is that after the tumor is removed, you do not have any means to address if the patient will or will not respond to the adjuvant therapies. So the more modern strategy includes the use of neoadjuvant chemotherapy, in which the chemotherapy is moved to before the surgery. So this way, the tumor is on site when we are delivering systemic therapy, and we have means to address if the patient and the tumor is responsive or resistant to the therapy. That allows us to change gears in case of residual disease at the time of surgery. But again, when we start the adjuvant components of the therapy, we no longer have the tumor in place to be able to address if the patient will or will not benefit from that particular intervention. Excuse me. So neoadjuvant chemotherapy has become the standard of care treatment for patients with early stage disease, especially for those with high-risk disease. And since it is done before the surgery, we use that information to address if the tumor is going to be responsive to the intervention. However, we have a report, several reports of the effectiveness of this treatment ranging from 10 to 65%. And that is related to either the type of tumor or the type of treatment. So one of the main endpoints for the neoadjuvant therapy is the number of patients who achieve a pathologic complete remission, PCR, at the time of the surgery. And the trials describe anywhere between 10 and 65% of PCR rate. So you see that this is a very heterogeneous group of patients. And so we need to get down to details about the disease to be able to make better than that, And so we know that if the patient gets to a PCR, that patient belongs into a group of much better prognosis. And a PCR has been well established as a surrogate endpoint that is even used for regulatory approval of potential therapies. So the major challenge that we clinicians have when we are in front of the patient is to try to enable each and every one of the patients to achieve a PCR, right? And by doing so, doing it with the minimum possible toxicity. So that is where the biomarkers come to place, because we need to try to understand if that intervention is, number one, tolerable, and number two, effective to get to that aim. The main issue is that for those patients that are non-responders, we would like to be able to switch gears and change therapy so that we can get them to PCR. And for those patients who have early evidence of maximum response and potentially PCR, predicted PCR, we would like to be able to stop the therapy before surgery and prevent them from being exposed to more toxic agents. And so the I-SPY 2 clinical trial is an ongoing multi-center open-label adaptive phase 2 platform trial in which multiple experimental groups of therapies are evaluated in the neoadjuvant setting for patients with high-risk early-stage breast cancer. And so the new arms are added to the study by the means of amendments, and arms that complete the enrollment come off the study also through amendments. And so patients that get into the study may be randomized to one of the arms that is relevant to their disease and will be treated before surgery until we get to the information from pathology at the surgery, which is going to be our endpoint, to see if that treatment was effective or not. So the main aim of the study is to identify agents or regimens that would improve the chance of PCR in combination with the standard chemotherapy. And the overall goal of the study is to improve the way we evaluate new treatments, right? So we want to accelerate this evaluation. We want to make sure that we acknowledge the heterogeneity of the disease. And we also want to be able to identify additional endpoints that are relevant to this process. We are looking for big signals in this trial. And most importantly, there is a high demand. The patients want to do something different, something that may be potentially better than what is available. And so in terms of the statistics, this is, as I mentioned, the primary endpoint is the PCR rate. We have a maximum of 5 new drugs tested simultaneously for a particular subtype of tumor, and no more than 120 patients per arm. And then we have a sequence of biopsies and MRIs that are done during the treatment before the surgery to allow us to address if this patient is getting the response that is expected. And then we have Bayesian methods to guide the randomization by which that arm that has a higher chance or higher incidence of PCR is the arm that is preferred for the next patient to be enrolled to. So that is also in the best interest of the patient. And then the enrollment to a particular arm may stop basically because of one of the 3 reasons that I mentioned there in the slides. First, you see that if there is a Bayesian probability, a predictive probability of a success of that arm in a clinical trial with 300 patients, we stop the trial because this is a graduated agent that can graduate to a phase 3 environment. We also may stop the arm in case of futility. let's say that agent or that combination is not really reaching the percentage of PCR that we expected. That arm has to stop because of futility. And then, of course, there is a third reason, which is unexpected toxicity. Remember, these patients are being treated in the curative setting, right? And so the I-SPY trial has a very strict safety monitoring process in place to ensure patient safety. And so here I am showing you on the left of the slide an example of an MRI of a patient treated with chemotherapy plus pembrolizumab, which is one of the graduating arms of I-SPY 2 that was later confirmed in a phase 3 clinical trial and is currently the standard of care for patients with triple-negative disease. You can see the baseline MRI here with the tumor and then the complete disappearance before surgery. And on the right, you can see an event-free survival, a curve of patients. This is when we had approximately 990 patients evaluated from all arms of I-SPY at that point, in which you see that patients who have a PCR, doesn't matter the histology, doesn't matter the treatment they received. If they have a PCR, they have this type of predicted survival, event-free survival, while if they don't have a PCR, they belong here. And this is irrespective of the treatment. So we see that we would like to get treatments lined up to try to make more of these patients here to jump to this other curve here of PCR. So we have biomarkers of response and non-response that drive the progress in this trial. We have the options of, as I mentioned, the imaging, and then multiple other techniques that involve the specimen collection. And then we now have more than 90,000 specimens that are well annotated with survival information from the I-SPY 2 trial that we use even to plan next arms that are coming up, sometimes with drugs that back then we didn't even know they existed, but are now coming up as potential options. And then based on the history of biomarkers from the study, we can go back, we can look up at the potential target and say, well, this is a drug that we would like to test for this particular group of patients with early-stage breast cancer, as long as there is safety and efficacy in early stage for that particular compound. And so this is one of the powers of a long-lasting platform study. And so the biomarkers on I-SPY 2, we have the standard biomarkers that involve the receptor status, estrogen, progesterone, and HER2. And then we have MammaPrint, which is already one of the molecular assays that allows us to define if the patient has high-risk disease or low-risk disease. As you know, MammaPrint is an European assay. And then we have the MR volume based on a volume. It's a different type of MRI than what is used in the routine radiology. This is a special type of MRI involving a measurement of volume and with different types of exposure and contrast that allows us to better estimate the response to therapy and the lack of response to therapy as well when we have to move forward faster. And then we have qualifying biomarkers that are in the middle column. These are signatures that we have been developing, and I can show you number 5 there is an example of the immune signature is graduating from qualifying to standard in I-SPY 2.2. And then we have the exploratory biomarkers, and I can give you the example number 3 there on the far right. Of circulating DNA that is being done now on every sample, for every patient with the blood samples, because it seems that this is also very important for the estimation of response to therapy before surgery. And then I want to spend just a couple of minutes on this slide. It's a recent publication that involved the analysis of 990 patients enrolled in multiple arms of I-SPY 2 that led to the update of the study to I-SPY 2.2. So on the left side of the Sankey plot, you see the original way to classify breast cancer, which is CR, PR positive, HER2 positive, triple negative. And then on the right side, there is a different classification. We call it the RPS, the response predictive subtype. And this is based on the implementation of classification, also based not only on the receptors and histology, but also, and MammaPrint, but also the DNA repair deficiency signature, the immune signature, and also the blueprint signature. And this actually, it's a little bit small, but I hope that you can appreciate that, for instance, in patients with HER2 negative, immune positive disease, triple negatives upfront, or ERPR positives upfront, this is about 38% of the patients in the sample, we would expect a 79% PCR rate with chemo plus pembrolizumab. Remember, in I-SPY 2, pembrolizumab graduated both for triple negative and for ERPR positive HER2 negative disease, though it is the standard of care now for triple negative alone, an ongoing trial for the ERPR positive disease patients. And so this is actually a bar that is very high to beat, right? So here is an example of a situation in which we would be looking at ways to minimize toxicity, right? Because it's very difficult to get much better than 79% probability. Another such high probability of PCR is for the patients who have HER2 positive disease, that is a blueprint HER2 enriched or basal, which is about 19% of the patients. The probability of PCR with the usual THP, which is a taxane with trastuzumab and pertuzumab, chance of PCR 78%. But then look at the, for instance, this large group of patients here, 29% of the patients. These are patients with ERPR positive, HER2 negative disease, immune negative, DRD negative. The ACT, standard of care treatment has a chance of PCR of 8%. That's what we do for everyone walking through the door. So you can imagine that the patient is not happy with that. The physician is not happy with that. And so we want to do better, that this is a great unmet need here. So we're looking for drugs that can do much better than that. And for I-SPY 2.2, the futility is lower and the success bar is also lower because we are talking about PCR rate of 8%. And someone may say, well, but these are ERPR positive, HER2 negative disease and they don't respond to chemo. Remember, the patients here with this disease are selected for high risk, high molecular risk by MammaPrint. So the vast majority of the luminals are out of this picture. So I really am talking about patients with high-risk ERPR positive, HER2 negative disease here. And so on and so forth. So this, based on this, the study was updated to the new design, which is the I-SPY 2.2 design. And so, and before I get there, just to remember that in 2020, the study was amended to allow us to skip the AC chemotherapy, because remember, AC is what can cause heart failure, leukemias, lymphomas, so people are very hesitant about using AC, but it's a very effective drug. But see, if the patient has a PCR, predicted PCR after the taxane plus investigator agent before starting AC, they are allowed to skip AC and go straight to surgery. So, because of the sake of time, let me just move on. So the only thing that I wanted to mention about this slide is that this is the design of I-SPY 2 with multiple arms with the backbone of TAC with the investigational agent here, in which we are really looking at outcomes that are better using molecular markers for treatment assignment. And now we have this different design that is the I-SPY 2.2, in which we have the experimental agents here, the backbone with the taxane here, and the rescue with the anthracycline-based regimen here, with the possibility of surgery at each node between the blocks. in which we are really trying to tailor the treatment according to the patient, the individual patient response. And so just a bit larger here for us to see this. Novel regimens go to block A. If the patient gets a prediction of PCR based on labs and MRI, the patient can go straight to surgery. If not, then we do the block B, which is the best in care, standard of care or best in I-SPY, which is typically Taxane combined with some therapy, for instance, immunotherapy for triple negatives or carboplatin, so on and so forth, and maybe randomized here to try to see if we can get less toxicity. And then if still we predict lack of PCR, then we go to the AC. And so we really need a better understanding of the biology of responders and non-responders, and we do have the tools to get to that information. And so what we are trying to do now is to actually direct the new regimens through the block A to allow us to put them in this stepwise fashion evaluation of efficacy and safety for these patients with early stage disease. I wanted to mention that this is a national effort, essentially concentrated in academic centers in the US, but with a lot of collaboration. And the conclusion here, I will just focus on the vision of I-SPY 2.2, which is to make new, better, and more personalized treatments available faster at the time when the patients need the most. And with that, I would like just to thank all the patients and investigators of the study and the participating organizations and funders for this large study. Thank you.